Good afternoon. Welcome to Session 13, SAM's Session 3 Post-Treatment Imaging. My name is Edward Castle from the University of Toronto, and I will be the moderator for the first three presentations. Our first speaker of this session will be the very talented Amanda Corey from Emory University, Atlanta, discussing the spectrum of flaps used in reconstructive head and neck surgery.
Thank you to the ASHNR 2020 Program Committee for inviting me to speak. I have no relevant financial disclosures. This talk is based upon the educational exhibit presented at a previous ASHNR and our subsequent publication in AJNR. I would like to acknowledge Dr. McCarty's work on these projects and her illustrations. Her illustrations are all marked with her signature stamp. I would like to thank my surgeon collaborators from Emory, Dr. Eldiri and Dr. Badur, for providing the operative photographs and surgical insight. Post-treatment imaging is an important part of cancer surveillance. The altered anatomy in these patients following oncologic surgery and head and neck reconstructive surgery is complicated. Over the next 30 minutes, I hope to improve your understanding of free flaps. While often used interchangeably, grafts and flaps are not the same. Grafts bring with them no intact vessels for surgical anastomosis, but rather rely on angiogenesis in the bed for viability. Meanwhile, vessels are an integral component of flaps. Flaps can be classified either based on type of tissue transfer or tissue constituents. Local flaps close small defects. The local flaps are raised from tissue adjacent to the primary defect and advanced into the defect. The donor tissue brings with it intact vasculature. Pedicle or rotational flaps, such as the pectoralis major muscle flap, can be used when inadequate tissue adjacent to the defect exists to allow for primary closure and coverage. These regional flaps are harvested from tissue nearby and then rotated into the recipient site, leaving the flap's own vascular pedicle intact. Free flaps, on the other hand, are raised from tissues distant from the surgical defect and transferred into the defect en bloc. The donor blood vessels are anastomosed with size-matched recipient blood vessels. These back table intraoperative photographs show examples of a tubed fasciocutaneous flap as well as an ALT flap, where the skin and subcutaneous tissues can be seen. But the hallmark feature of the free flap is this vascular pedicle. There are a variety of free flaps. Most were utilized outside the head and neck initially, and then about a decade later applied in the head and neck. We'll take a closer look at some of these flaps, including the myocutaneous rectus abdominis and latissimus dorsi flaps, the fasciocutaneous radial forearm and ALT, the osteocutaneous fibula and scapula, and the jejunal visceral flap. Flaps need to combine form and function. They provide a protective function for the vital structures exposed during oncologic surgeries. As we see in this example, a free flap fills the surgical defect at the skull base. This aids in healing and also protects the skull base and vital structures transiting this area. Flaps are used to restore function, such as the ability to eat or swallow or talk. Following glossectomy and free flap reconstruction, this patient had intelligible speech and was able to maintain some normal swallowing mechanism. Flaps help restore facial and neck symmetry. This fibular flap reconstructed the right hemimandible and restored near-normal architecture to the lower face. The ideal flap lives at the intersection of these three aims. The overarching goal in these cancer patients is for the surgeon to resect with clear margins to improve survival, and at the same time be able to minimize complications of these big surgeries by utilizing free flaps for defect closure. Before the patient even goes to the operating room, so many factors come into play with flap selection. For example, the oncologic defect will dictate what needs to be replaced and how big the flap will need to be. The goal is to replace like tissue with like. Flap choice is also influenced by patient's preference, as well as body habitus, vascular integrity, prior surgeries, or radiation. And of course, the surgeon's skill set, preference, hospital support, as well as OR time will be factored into the decision. The radiologist's role in the preoperative setting is varied. Importantly, we need to outline for the surgeon the extent of the primary tumor. The surgeon needs to know what will need to be replaced and should be able to gauge the bulk of soft tissue needed to fill the oncologic defect. Here the tumor invades the base of tongue and extends into the oral cavity and larynx. They will need a total. In this patient, the mandible will be resected. The skin of the anterior lower face will need to also be replaced. The donor site will sometimes be assessed looking for soft tissue and vascular abnormalities. CTA, MRI, or ultrasound may be used to assess the donor site. At the recipient bed, the vasculature used for anastomosis will have to be assessed. Most commonly, branches of the external carotid artery, including the facial, superior thyroidal, and lingual, are used for the microvascular anastomoses. Preoperative assessment using CTA is sometimes performed to evaluate the caliber of these arteries. However, on a well-timed CT scan of the neck with contrast, we should be able to provide the information about these vessels. Now, this patient had a CTA, and we can see the high-grade stenosis of the distal common extending to involve the origins of the ECA and ICA. Anastomosis on this side would not be possible. In this MRA runoff of the lower extremities, peripheral vascular disease is evident, and it would not be possible to harvest a fibular free flap in this patient. Before we move on to reviewing the specific flap types, I'd like to start by providing a general introduction to the appearance of a flap. We need to keep in mind that the appearance of a flap will depend upon the components in the flap. Also, the appearance of the flap can change over time. In the event there's denervation and the flap undergoes atrophy, or the patient is radiated and the flap contracts. Flaps with intact innervation do not undergo fatty atrophy. This patient had a rotational left pectoralis major muscle flap to close a large anterior neck defect and support a stoma. We can see the vessels that would have been exposed, carotid and jugular on both sides, portion of the thyroid gland. Here's the stoma that's being supported by this tunneled pectoralis major muscle flap. It's also covering the lower portion of the surgical reconstruction of the upper alimentary canal. You can see the muscle bulk here, striations of the muscle, the subcu fat, and skin. This patient also had to undergo a reconstruction of the alimentary canal after a salvage total laryngectomy. The reconstruction was a tubed ALT flap. We can see the fat from the subcu location and the skin here recreating the neopharynx. Again, we want to look for clean fat, clear interfaces, and a monotonous appearance to the mucosa. Post-contrast enhancement in a flap should be similar to the adjacent muscle in the myocutaneous flaps. However, if the flap got radiated, you will sometimes see increased enhancement and increased T2 signal. The muscle should be iso-intense to other muscle that has not been rotated or translocated into the surgical defect. There should not be nodular enhancement, and the flap should not increase in bulk. Anytime a flap increases in bulk, you have to worry about a tumor recurrence or infection. So after that brief overview, let's take a look at some of the specific flap types. We'll start with the myocutaneous free flap. These are made up of muscle and can include the overlying skin as well as intervening fat and fascia. The two most common myocutaneous flaps are the rectus abdominis flap and the latissimus dorsi flap. The rectus abdominis flap is versatile. It's a very large flap, if necessary, and is good for filling big defects at the skull base and orbit. You can actually get up to 2 skin paddles, and you get a very long vessel. A large caliber vessel for anastomosis is also available with the inferior epigastric trunk. Given the fact that the patient is supine for most oncologic surgeries and would need to be positioned supine for a rectus abdominis harvest, the oncologic surgery as well as the harvest can take place nearly simultaneously. That cuts down on OR time. Donor site morbidity includes an anterior abdominal hernia. In the rectus abdominis free flap used to fill a defect, this is a nice example. We have a patient that had recurrent basaloid carcinoma following a previous resection. So it was a maxillary malignancy. It is creeping up into the orbit. So you're going to have to undergo a mid-face as well as an orbital procedure. This large defect resulted in exposed skull base and a large mucosal defect in the oral cavity. The beauty of the rectus abdominis flap with the muscle component, which can be used to close the skull base defect, is that you have this large amount of skin. The skin surface will be used to recreate the mucosa in the oral cavity, but also to provide coverage for the external portion of the surgical bed. This is a 3D surface rendering showing the bulk of this flap. Certainly in the obese patient, the bulkiness of this flap can be problematic. But this flap will atrophy over time and may not require any sort of debulking procedure for cosmesis. Additionally, if the patient were to go on and get radiation, the flap will contract. Latissimus dorsi flaps have only minimal donor site morbidity, and they represent the largest of the muscle flaps. Their available skin paddle, however, is smaller than the rectus abdominis flap. These flaps are based upon the subscapular pedicle and offer the option of bringing a portion of the scapula or a rib if bone is also needed. The donor site can be closed primarily, doesn't require a split thickness skin graft. However, as you can see from this photograph, the disadvantage of this flap is that the harvest requires the patient to be in the decubitus position. So simultaneous oncologic surgery and flap harvest are therefore not possible, which extends the operating room time. The surgeon marks on the patient the important landmarks, including the latissimus, the vascular pedicle, and the bony scapula. This patient had a squamous cell carcinoma of the oral tongue that spread into the oropharynx and also into the larynx. A glossectomy, laryngectomy, and oropharyngectomy had to be performed. This is the back table view of the harvested latissimus dorsi flap. We can see the muscle bulk, the smaller skin paddle, and there is our vascular pedicle. This is an intraoperative photograph. What we see here is the posterior pharyngeal wall, which did not have to be removed as it was disease-free. The surgeon's fingers are reflecting the anterior neck tissues and skin, and we can see the flap has been anchored in at the cervical esophagus. This flap is reflected up on itself, almost as if you were closing 2 halves of a book, and then will be secured along this posterior pharyngeal wall to recreate the conduit for food and liquids from the mouth to the esophagus. The flap is then pulled up into the oral cavity and anchored into the floor of the oral cavity, providing this recreated oral floor. The goal is also to have a mound posteriorly to aid in swallowing and speech. The muscle will help reconstruct the mylohyoid sling at the floor of mouth. And this skin surface, again, remember the mucosa can be reconstructed with epidermal skin, is reconstructed here. Moving on to fasciocutaneous flaps. These contain fascia and overlying skin as well as subcu fat. They contain an epithelialized component, and therefore they can be used to restore skin or mucosal defects. These flaps are unique in that they can also be tubed or rolled to form a conduit. The two most common of these flaps are the radial forearm free flap and the anterior lateral thigh flap. The radial forearm free flap is a thin, pliable flap, often used in the oral cavity. It can be tubed to form a conduit if the neopharynx needs to be created. This area has relatively little hair, even in men, which is often important cosmetically. Unlike the ALT flap, weight fluctuations and obesity are less likely to affect the size of this flap. A drawback of the flap is that this defect will have to be closed with a skin graft. If necessary, up to 12 centimeters of partial thickness radius can also be harvested, so you can get skin, fascia, and bone if necessary. These flaps are based upon the radial artery. The surgeon in the preoperative setting will identify the radial artery using ultrasound. He has marked his desired skin paddle here. It is important to perform an Allen test preoperatively to ensure adequate blood supply to the hand from the ulnar artery and avoid catastrophic ischemia after surgery. There is moderate donor site morbidity, which includes edema of the hand following surgery. This is the appearance of an in situ, mature radial forearm free flap, reconstructing the gingiva of the oral cavity. This is a common use for this flap. The ALT flap is one of the first-line reconstructive options for soft tissue defect in the skin and upper aerodigestive tract. This flap-related perioperative mortality is almost non-existent, and the donor site morbidity is one of the lowest of any free flap reconstructive options available. This flap is based on the lateral circumference artery. If needed, a portion of the vastus muscle can be included to aid in bulk, or if there's a skull-base defect that would need to be closed. This flap is widely used in Japan and Taiwan, but not as commonly used in the United States because of obesity, making this flap too bulky to give cosmetic result that's satisfactory. This intraoperative photo shows the anatomic landmarks important to the surgeon and include the anterior superior iliac spine as well as the lateral patella. The large circle shows the skin paddle, and the dog ear defects are used to ensure a primary closure. No skin graft is necessary for these defects. This portion of the body doesn't get as much sun as, say, the arm, and so it offers a good color match for repair of facial or scalp defects. While peripheral vascular disease can be a factor with fibular flaps, peripheral vascular disease is typically not an issue with ALTs. This is a back table view of the harvested tissue. This flap can offer a very long vascular pedicle and allow for contralateral neck anastomosis. Here are two intraoperative photos from ALT flaps. Notice the good color match that you can see and the varied size these flaps can come in. This patient had a large oral tongue cancer and was going to undergo glossectomy. The flap has been insect following the glossectomy. Here is the maxilla and the mandible. The flap is secured at the base of tongue area and then is folded upon itself. We get a large mound in the back of the mouth, which is desirable. This is a different patient, but the same surgery was performed. Notice the mounding posteriorly, this monotonous fatty attenuation of the flap, and the smooth surface of the skin in the recreation of the floor of mouth. These patients have intelligible speech. When tubed or rolled, the fasciocutaneous flap can form a conduit. The skin side, epidermis, is rolled inward, and the subcutaneous fat is on the outside. So that's important to remember when you're looking at imaging. This is a CT of a 53-year-old man with a history of unknown stage supraglottic laryngeal squamous cell carcinoma. He had chemo and radiation, but recurred 2 years later. This bulky recurrence is at the level of the hyoid, but does extend both superiorly and inferiorly. He underwent a total laryngectomy, partial glossectomy, an oropharyngectomy, bilateral neck dissections. So there was a lot taken out, and the alimentary canal needed to be reconstructed. 3 months post-op, his tubed flap looks like this. You see this subcutaneous flap fat, which is rather scant by comparison to some of the other examples I've shown you. And then the mucosa has been recreated using the skin. Osteocutaneous flaps. They are, the two common ones are going to be the fibula and scapula. And again, you have the option of including some adjacent muscle with these flaps if necessary. The fibular free flap is based on the perineal artery and vein. You can bring portions of flexor hallucis longus and posterior tibialis or soleus if necessary. The fibula is actually nicknamed the most donatable bone in the body. Its tubular shape and thick cortical bone make the fibular free flap one of the strongest osseous flaps. It can be harvested with skin or without skin as a free osseous flap. There is often little effect on gait, and this is a well-tolerated procedure. Preoperative workup in these patients, though, does include lower extremity vascular imaging. The anatomic landmarks for a fibular free flap for the surgeon include the lateral aspect of the fibular head and the lateral malleolus. Here is the planned skin paddle outlined, as is the entire shaft of the bone. This back table view shows the skin paddle, the portion of the fibula resected, and the intact periosteum and portions of the muscle. You can actually get up to 25 centimeters of tubular bone from a fibula. It is desirable to have this full thickness of bone if dental implants are to be considered in the future. And it is important to remember that vascularized bone holds up better when exposed to radiation than non-vascularized bone, minimizing or at least decreasing the chance of osteoradionecrosis. Depending on the size of the skin paddle, it's actually possible to have primary closure. Otherwise, a split thickness skin graft will be needed. Given the remote nature of the fibula from the head and neck, you can have a simultaneous harvest combined with the oncologic surgery if you have a 2 surgical team available. These CT images, including the 3D recon, show a large mandibular cancer with definite bone loss. Patient will need a segmental resection. This is the intraoperative view following inset of the fibula. You can see the recon bar bridging the fibular graft or flap and securing it to native bone. The postoperative result is wonderful. You've got a nice normal anatomy restored. In this case, the bone looks healthy. The cortical bone thickness is maintained. The medullary cavity fat looks clear. The osteotomies have healed, and the flap to native bone anastomotic site is healed. The scapula flap is extremely versatile. You can take up to 3 separate bone islands and up to 2 separate skin paddles, all based on the subscapular artery. This allows for complex midface reconstructions where the palate and the orbit need to be reconstructed. Of course, the scapula harvest is a little more complicated. The patient has to be moved, so the two surgeries cannot be performed at the same time. It extends operating room time. There is some morbidity associated with this procedure, including pain, decreased range of motion, and a winged scapula. But physical therapy does seem to help minimize these side effects. Visceral flaps used in the head and neck include omentum and jejunum. As a mucus-producing tubular structure of similar size, the jejunum seems a natural replacement for the cervical esophagus. Upon transfer, the jejunum retains some of its contractility, and that can actually be beneficial for swallowing, provided the flap is inset correctly. This flap is fragile, doesn't tolerate long periods of ischemia, and there's some morbidity associated with small bowel resection. However, with this flap and a TEP, the patient can maintain speech. The back table view shows the harvested jejunal segment with its vascular pedicle intact. The intraoperative photo is following a total pharyngectomy, and cervical esophagectomy. In this photograph, we're actually looking at prevertebral fascia, and they're the carotid arteries. And the airway is being maintained by that tube. In this photograph, the jejunal segment has been inset, secured inferiorly to the thoracic esophagus and superiorly to the oropharynx. The glistening appearance, the turgid appearance of this flap is exactly what you want to see after the anastomosis has been performed. Here's a patient with recurrent head and neck cancer that involved the larynx, hypopharynx, trachea, and cervical esophagus. Post-op imaging shows the jejunal free flap inset, reconstructing the upper alimentary canal. You can notice this kind of almost undulating pattern that you would expect from the small bowel along the mucosal surface, and there's a small amount of omental fat surrounding. We're going to quickly go over an approach to a post-op case and point out some things that are important to remember as we start looking at these patients. First of all, open the chart. We want to know about what the tumor type was, where it was located, were the margins negative at surgery, did the patient get treatment with chemo and radiation, what is the timing of this scan relative to the last treatment. Also, it's important to know whether the surgeon found anything on physical exam or if the patient has any concerns. Old is gold. Always get those comparison exams, including the scan showing the tumor. That exam will be so helpful as it will tell you where to look for the likely recurrence site, as a tumor likes to recur along the margin of the resection bed. Complementary studies are helpful. Metabolic imaging or MRI can give additional information to just the CT. Once we have all our ducks in a row, know what's going on with the patient, we're ready to look at the exam, keeping in mind to look for recurrence in the operative bed and along the surgical margins. Remember that an increase in bulk is never normal. A patient complaining of pain is worrisome and should put you on high alert. Occasionally, we are asked to scan patients for complications. The non-vascular complications that we encounter can be a fluid collection, like an abscess, hematoma, chyle leak, serous retention, and this will overlap with the appearance of a wound infection or flap dehiscence. Tumor recurrence can occur early, prior to radiation, and you always need to be looking out for that. Here's an example of a wound infection. This patient had a large T4A oral cavity cancer. They underwent a total glossectomy and mandibulectomy that was closed with two flaps, both a radial forearm and a fibula. 4 weeks post-op, they presented with a fever, white count, and drainage. It is no mystery that this is a wound infection. You can see the neck is dehiscent, phlegmonous changes in the periflap region, and marked edema. Flaps can break down through vascular insufficiency. In this case, they had a non-healing oral commissure eschar. The reconstruction bar was actually visible, and the bone is exposed. Notice how unhealthy this fibular flap looks. There's sclerosis in the medullary cavity, there's periosteal reaction, there's some areas of irregular thinning of the cortex. This is what it should look like: healing osteotomies, well-secured hardware, adequate coverage with soft tissue. Late complications include osteoradionecrosis, hardware failure or exposure, ossification of the vascular pedicle. Infection and inflammation can occur at any time, and of course, you can have tumor recurrence. This is the best case of hardware exposure I've seen. Hardware exposure or extrusion is actually the most commonly cited complication, and there's an increased incidence in patients who continue to smoke. This patient had an oral cavity mouth cancer with extensive bone involvement. A composite resection and recon were performed with a rotated pec flap as well as this recon bar. Primary osseous reconstruction was not completed as the patient had severe peripheral vascular disease. The patient was lost to follow-up and rolled into clinic 4 years later with their recon bar completely uncovered, and they were still smoking. Here we can see the pectoralis major flap that was used to close the anterior neck defect, and you can see a portion of the stomal collar. In closing, I hope you have a better understanding of the common free flaps used in head and neck reconstructions. These cases are complex. The baseline postoperative exam is often the most challenging, but with a structured approach to these patients, the imaging interpretation can be more straightforward. Thank you for your attention.
Our second speaker, Pat Reimer, has had a tremendous influence on the society over many years, both in direction and strength of the educational program and the mission of the society, as well as its leadership. Pat is currently stationed at the Jacksonville, Florida Mayo Clinic. Her topic is post-surgical imaging, reconstructive changes versus recurrent tumor.
Hello, my name is Pat Reiner, and I am happy to see you all here at ASHNR. It's a new year, a different type of meeting, and I know next year we will all be back together and sharing some of the advantages of ASHNR, one of which is the socializing. I am delighted to be in the session of post-treatment changes. I've been asked to speak about how to tell the difference between a reconstructive change or recurrent tumor. And you just saw a great talk by Amanda Corey on reconstructive changes, and now I'd like to talk about some of the appearances for recurrent tumor. I have no conflicts that would impact this presentation. There are certain steps I go through when I'm looking at a post-treatment neck and cross-sectional imaging, and for the most part, in my practice, we use CT because we couple it with PET. So most of my images will be PET and will be CT, and some will be MRI. The first step is to know the original tumor type and the location. And by location, I mean subsite. Was the primary tumor in the nasopharynx, oral cavity, oral pharynx, larynx, or hypopharynx? That is what I mean when I say the location. Hopefully, the first post-treatment scan is at 12 weeks. In that way, the post-surgical and post-radiation swelling will have resolved. The scan that you're looking at, know what was done. Know if they did just a local excision of the tumor, if they resected without reconstruction, or if they resected the mass and did a flap reconstruction. If you know or are told that the patient has pain or a new cranial nerve deficit, in general, there is recurrent tumor, and spend some time looking at the imaging until you can find it. And finally, part of our responsibility is that if we see something that is worrisome, we have to be able to recommend a method to prove recurrence. It's why I like the NIRADS approach. If you don't use NIRADS, it doesn't matter. Still have a manner to direct the referring physician of how to prove recurrence. Either recommend direct exam and tell them exactly where, or image-guided biopsy. And that, of course, is our responsibility. So there are a variety of different flaps and different post-treatment changes we might be dealing with. Local resection is just soft tissue resection only. Composite is a term used for surgery for oral cavity tumor, and it generally implies both bone and mucosa have been resected. And of course, the bones are mandible or maxilla. A composite resection with reconstruction with a free flap means the surgeon has put something up to close the wound. It may just be soft tissue, or it could be soft tissue and bone. And then know if they've done a luminal flap. If there is a pharyngeal and esophageal resection, the pharynx and the proximal cervical esophagus, or even the distal esophagus, will need to be reconstructed, and that's done with a luminal flap. In the goals of this surgery, regardless of where they're operated, regardless of the subsite, the number one goal is local control of the malignancy. That is the very first thing that they want to be sure they can do. Secondly, they want to be able to repair that surgical defect, fill in the site where they resected the tumor. It is important to maintain function, and in the head and neck, that's generally chewing and swallowing, to maintain nutrition and voice. And finally, one of the goals of the surgery is cosmesis, to restore the face and the neck to what the patient looked like before they had the surgery. Number one goal, local control of the malignancy. So in the setting of a local excision of primary tumor without reconstruction, the recurrent tumor looks like the primary tumor. You'll see in these three patients, these are classic examples of recurrent tumor. This patient has been operated for a buccal mucosal tumor, and we see a mass, a discrete mass in the buccal mucosa at the maxilla. It's enhancing classic appearance for recurrent tumor. Here's a patient who had a segmental mandibulectomy for oral cavity tumor. Here on the retromolar trigone, there is a discrete mass that with enhancement. Those are the classic CT findings of recurrence. And finally, here's another patient who had a buccal mucosal resection, and there is a large discrete mass. It has invaded and replaced the masseter muscle. It's wrapped around the outside of the zygoma. Look how it's come and filled the retroantral fat. Look at the normal fat on the contralateral side. And it's completely effacing the inferior insertion of the temporalis muscle on the mandible, which is what we see right here, the normal temporalis muscle. And notice there's some erosion of the anterior ramus of the mandible. This is a discrete mass. These are the classic imaging findings of recurrent tumor after a local resection without reconstruction. This is another example, a luminal or laryngeal example. A patient's had a partial supraglottic laryngectomy. The voice is getting worse, and we see here a classic recurrence. It is a discrete mass along the anterior wall of the proximal tracheal ring. There's destruction of cartilage, and the tumor is now extra-laryngeal and extratracheal. It looks like a mass. That is recurrent tumor. In the larynx, after radiation, you will often see some swelling and edema in the soft tissues. These are the aryepiglottic folds that are markedly swollen, but notice they have a lower density than this recurrence over here. And I call that mucoid density. It's a buzzword when I dictate that it is not recurrent tumor, but it is a benign post-treatment change. In those patients who have had a resection and a reconstruction, the goal is to determine what kind of reconstruction they had and to carefully assess the flap. Here's a patient who had a T4A squamous cell carcinoma of the oral cavity. This has been resected. The patient has had a total glossectomy, and the oral cavity was reconstructed. The tongue was reconstructed with a fatty-free flap. This is the initial post-operative image. So we know the post-surgical edema should have resolved, and now it's a good time to look for residual or recurrence. The flap itself is nice and fatty, homogeneous with these thin septations and vessels. We'll be looking carefully at what's called the recipient bed around the boundaries of the flap. In oral cavity flaps, it's very important to look around the hyoid bone because oral cavity tumors often recur down around the hyoid bone. So the flap itself should be relatively homogeneous. It should not be dirty. We should not see dirty fat. There are the septations that you always see in a fatty flap. You'll see some vessels, as we see right here. But the critical place to look carefully is at the recipient bed, that interface between the flap and the native soft tissue. So along the lateral pharyngeal wall, this is where the flap has been sewn in. We're looking here for any nodularity, any mass, any local induration of the fat. This flap has also been laid carefully along the posterior pharyngeal wall, right near the carotid sheath and the styloid process. No nodularity, no mass, and no abnormal enhancement. And then laterally, we're going to look for the same thing, nodularity, and this looks very clean. Notice that the flap has been used to reconstruct the anterior wall of the swallowing tube, if you will, the neopharynx, and a look at it's anastomosed laterally and medially to the normal tissues. That's the new anterior wall of the neopharynx. On the sagittal reconstruction, we're going to look very carefully around the hyoid bone and look for any nodularity, any abnormal enhancement, any frank mass. So the buzzwords I use in my dictations are at the intersection with normal tissue, it is thin, non-nodular, with no enhancement. In patients who've had a flap such as this that is partially fatty but partially muscle, you'll often see some atrophy in the muscle, some fatty atrophy. It will be isodense to muscle elsewhere. It's isodense here to the temporalis muscle and very little mass-like enhancement. So what we see here, we would dictate this as both a fatty and a muscular flap. The fatty component is clean with no induration. The muscular component is relatively atrophic. It's isodense to muscle, and there's no abnormal enhancement. And that would be a good way to dictate this benign appearance to this post-treatment scan. Tumors often recur around the flap or the reconstruction. And they usually, when they recur, it's often not in the flap itself, but at that boundary, at that interface with the normal tissues. So here's a patient who's had a partial parotidectomy for a malignant tumor, has had resection of much of the skin under the ear and probably the auricle itself, and has been repaired with this predominantly fatty flap. The flap at the recipient bed here looks fine. It looks thin, non-nodular, no abnormal enhancement, but here we see recurrent tumor. It's enhancing, it's relatively spiculated, has a very poor interface with the fatty flap. There's even some extension here to the skin. This really doesn't need a differential. This is recurrent tumor at the anterior margin of the flap in the parotid gland or parotid bed. Here's another example, and I'll just be showing a number of examples of recurrent tumor. Here's a patient who's had a partial glossectomy. This base of tongue and posterior oral tongue has been repaired with a fatty flap. And we can see there's no fat around this carotid and jugular sheath, so we know there's been a neck dissection. The flap interface looks fine here with the native soft tissue, but there's a discrete nodule with enhancement. This is recurrent tumor. Now, 2 months later, we can see how this has gotten so much larger. And there's probably another tumor deposit right there. But something that we may not have noticed was the recurrent tumor posteriorly. At this stage, we might have just interpreted this as the flap margin. It's not really mass-like. It's not particularly enhancing. And I think most of us, I certainly would not have called a tumor here unless I'd had a PET scan. Here, however, look at the difference. There's marked widening here of the posterior digastric and anterior sternocleidomastoid muscle. It's now filling in or extending into the fatty flap. It's really very poorly defined, and this is unequivocally 2 areas of recurrent tumor. Here at the interface with the residual muscles in the floor of mouth, and posteriorly at the posterior margin of the flap. Here's the lumen or the neopharynx displaced to the right, and the lumen is almost always eccentric to one side or the other. Here's another patient who's had a treatment. He's radiated, has had bilateral neck dissections. We see no fat around the carotid or the jug. That's a hallmark of a neck dissection. And here's the fatty reconstruction in the tongue. This particular image looks fine. Several slices inferior, we see a discrete mass. It's at the boundary of the fatty flap and the normal intrinsic tissue. It's mass-like, and there's peripheral enhancement. It's centrally necrotic. Those are the imaging hallmarks of recurrent tumor. 6 weeks later, look how this has progressed. Fatty flap, nice normal recipient bed right here. The necrotic mass is right here with a thick enhancing rind, and notice deep to it. This tumor has just spread posteriorly, and there's now peripheral tumor around the ECA branches, 180 degrees around the ICA, and notice the mass effect and narrowing of the internal jugular vein. So this was unequivocally recurrent tumor at this time. 6 weeks later, it's progressed and is much larger than it was. Here's another example of recurrent tumor. This patient has had radiation. You can see the brawny induration in the skin and the subcutaneous fat. Probably had a split mandible resection where the mandible was split to gain access to the floor of mouth. And the right posterolateral floor of mouth has been reconstructed with a fatty flap. These are the margins of the flap. And by the way, there probably was a muscle component to the flap too, right here, where we see edematous and relatively atrophic muscle. Here's the nice normal margin of the flap, but at this portion of the recipient bed, there is a large recurrence that has extended anteriorly and medially from the fatty component of the flap. Look at the coronal reconstruction. This is a classic pattern of spread for oral cavity recurrence. They extend down along the hyoglossus muscles and some of the extrinsic tongue muscles to the hyoid bone. There's destruction now of the right lateral hyoid bone, and this tumor really wraps all the way around the hyoid bone. If this patient elects to have more surgery, this patient will require a laryngectomy. Yet another soft tissue recurrence in the recipient bed. This patient's had a large neck dissection for nodal disease that was extranodal and poorly controlled. The surgeon has repaired the site with the fatty flap and a muscle base to the flap. The muscle has anastomosed here with the normal muscles in the neck. This anastomotic site or recipient bed looks fine. There's a characteristic peripherally enhancing mass, central necrosis at the recipient bed. This has all the hallmarks of recurrent disease. Necrotic mass at the recipient bed. Surveillance imaging in these patients is critical. At the first or even second scan, there may be some areas that just look a little irregular, but you don't see a discrete mass. And this patient is one such patient. Initially, I was worried about this area here, but this is easily assessed by the referring physician. They can look carefully to see if this is edematous mucosa or some candidiasis. This is not a mass. This was fine. And the lateral wall of the oral cavity and the pharynx have been reconstructed here with a predominantly fatty flap. The neoluminal surface looks good. This looks mucoid density, and it's also easily examined. And deep to this fatty flap, I don't see any mass or abnormal enhancement. 3 months later, look how different this looks. The styloid process is now surrounded by tumor. The tumor is extending into the posterolateral fatty portion of the flap. The tumor now is 90 degrees around the carotid artery. This looks so much different than it did here. And then 4 months after this scan, this has really, really progressed. Massive recurrence, nearly replacing the posterior portion of the fatty flap. Tumor now 180 degrees around the carotid. It's around the ECA branches, and look, there's thrombosis of the internal jugular vein. I would have called this negative here, tumor here, and then marked progression on that image. These are examples, or is an example of flaps that have recurred near a neopharynx. This patient has had a laryngectomy, a pharyngectomy, and has been reconstructed with a jejunal flap. The lumen, this is the neopharynx right here. The lumen looks fine, very smooth. Posterior wall of the neopharynx is often slightly thicker than the lateral or anterior wall. Carotid artery, jugular vein, and a large mass that is close to, but not within the lumen of this neopharynx. It's invading the fatty portion of the jejunal flap near some of the anastomotic vessels. Several images below that, massive, massive tumor, partially around the anterior common carotid artery, but still the lumen of this neopharynx looks clean. I would dictate this as an enlarging, solid, extraluminal mass that is inseparable from the left anterior internal carotid artery. It's a mass. There's really no differential. Now, if they've used bone in their reconstruction, it's of course important to look at the bone. Here's a large T3 maxillary sinus tumor, and the patient was resected and repaired with a flap with muscle and fat and part of the scapula. And so we're going to look carefully at the margins of the reconstruction. Notice the orbital floor and rim were repaired with a mesh, and the strut itself, the zygoma, was repaired with the scapula. The bone that is put up in a flap is often deossified and looks like this kind of bone. Deossified, but there's no destruction. Here's an example of a recurrence deep in the flap in bone. Now, this patient had another huge tumor in the maxilla, maxillary sinus, had an orbital exoneration. To fill in the empty socket, they put a muscular flap back here, and the anterior portion of the flap was fatty. And look what we have right here. The residual bone right at the interface of the flap is destroyed. There's a soft tissue component and destruction of this bone. This is very easy to biopsy with image guidance. It's really a straight shot, and you just get some cells from this area to prove that this is recurrent squamous cell carcinoma. These patients who require flaps in general have been operated for advanced tumors, and you can see recurrence that's relatively remote from the resection, but in the same subsite. So this patient had a right lateral oral cavity mass. You can see they've reconstructed the mandible here, probably with scapula or fibula. This poorly defined tissue has no recognizable anatomy, so part of this is also a flap. And on the initial scan, it looks good. This is the neurovascular bundle in the left sublingual space. But look what we see several months later. We see a robustly enhancing mass in the left anterolateral oral cavity, probably even crossing to the other side. So although the initial tumor was on the right, because these patients have such advanced disease, you have to anticipate they might have recurrences remote from that initial tumor. Tumors in the head and neck can recur in several manners. They can recur with direct extension, and that's what some of these recurrences that I've shown you have been: direct extension. They can extend through soft tissue and cartilage and bone, but they can also extend via small nerves with perineural extension. Other speakers in this session will be discussing lymphatic and hematogenous spread of advanced head and neck cancer. Here's that same patient with a very advanced maxillary sinus mass. You can see it's up into the orbit. The patient was resected, had a total maxillectomy, and this patient was repaired with a predominantly fatty flap to form the cheek. Again, there's mesh along the floor of the orbit. This is the muscular portion of the flap that's been put up there to reconstruct the face. And from the side, it looks great. But from the front, there's a large recurrent tumor. So the fatty reconstruction here looks great. This is scapula forming the bony orbital rim, and this all looks fine. But it is likely this tumor already had some perineural spread to some of these small sensory nerves in the lateral face around the orbit. And this is a classic spread pattern where it goes through small little foramen in the bony lateral orbital wall right into the lacrimal fossa. So this is a recurrent tumor via perineural tumor. So that too you have to be on the lookout for. There are three main mimics of recurrent tumor in a flap, and the first is inflammation. This patient's had a right parotidectomy, had a reconstruction with some skin and muscle to reconstruct the contour of the cheek, and the masseter muscle is very, very edematous. The subcutaneous fat is edematous, and the muscle itself and the perimuscular surroundings enhance robustly. It'd be hard not to be worried that this has tumor in it. It's so easy for us to prove it is or isn't. It's very superficial. Use some ultrasound guidance, get a number of samples, say from the muscle, maybe a couple samples here from the edematous and dirty fat, and this was all inflammation with no infection or no recurrent tumor. Infection is the second potential mimic. This is a very hard to recognize on one slice, but he had a complete glossectomy. They reconstructed him with a complex flap. There's a little bit of fat there, a little bit of fat there, brought up some fibula to repair the jaw, and some radial forearm. And now we see in the center an area of kind of what looks like an abscess. You get a sense there's a rim there. There's some bubbles in there. And this is a very suggestive of an abscess. And in fact, this was infected, and this entire flap had to be taken down and sacrificed. Here's another example of a post-flap infection. These infections are not going to be subtle clinically. This patient had a fever, they have white count, they have purulent drainage, and they hurt. And this is just a massive phlegmonous change in the reconstruction with some probably free pus right here around the fibula reconstruction. So infection is one of the mimics. The third mimic is necrosis. And necrosis is after they've had radiation. So this patient has had flap, and I want to point out that when you see lysis, whether it's on the native mandible or a reconstructed bone, when you see it on the lateral wall of the reconstruction on the buccal side, that's often osteonecrosis. And the recurrent tumors in general, unless they're very large buccal space tumors, tend to recur on the inner side. So usually I am worried about this being necrosis, and this was osteonecrosis. Here's another example of osteonecrosis. The other hallmark is when the bony portion of the flap or some of the hardware is exposed. It's sitting here in air. And it's in air because the surrounding soft tissue has necrosed. And this portion of the flap will have to be sacrificed. You might be worried about infection here. That's not a problem. But once you see part of the bone or part of the hardware exposed like this, that is very characteristic for necrosis. If you have a patient who's had a big head and neck tumor and there's new pain, especially in the ear, or a new neurologic deficit, worry about recurrent tumor. So this patient had a T3 oral cavity tumor, had a resection, but no reconstruction. This is not a flap. And now we see a denervation of the left tongue. So notice this is fatty and the tongue base is ptotic. It's hanging posteriorly. You can see there's been a left neck dissection, selective neck dissection. There's no fat here around the carotid and the jug. And this here's another look here at that ptotic, denervated tongue. And this tumor has recurred here in the carotid sheath. If I showed you an initial study, you would appreciate that this mass here was not there previously. So this mass, it hurts, this will hurt, and they often is referred to the ear. And remember, the 12th nerve runs for a while in the carotid sheath. It leaves the sheath around the inferior portion of the posterior digastric muscle, and that is the reason for new difficulty or garbled speech. So pain, especially in the ear or the throat, neurologic deficit, there is recurrent tumor somewhere. In summary, these are tough cases. And it's a bit easier if you can spend some time and know the primary subsite. You may be able to tell it just by looking at the scan. Know what was done and when. So know that you're outside that time frame of when you have post-surgical swelling. Very methodically, look at the reconstruction. Decide what are the components. Is it fat, muscle, or bone, or all three? Look carefully at the recipient bed and any bone used in the reconstruction or any residual bone that might still be there. Spend some time looking for destruction. And remember, some of the bone will look deossified but should not be destroyed. Beware ear pain, throat pain, and any new cranial nerve deficit. And last but not least, our job is to suggest that there is tumor and how to confirm the recurrence. Sometimes there's no differential. In this kind of patient with a jejunal flap, there's a mass that's all circumferential here around the carotid. There is no differential here. This is a large perijejunal flap recurrence. Remember this case, a nodule in the interface between the flap and the normal soft tissues. There's no differential here. This is recurrent tumor. But when there is a differential, it's important for us to be part of the solution This was a large mass. We weren't sure how to prove it. They couldn't see it endoscopically, so we did an ultrasound guided biopsy. You just need to do 3 passes in here, get a lot of material, put it in for cell block, and you can prove that this is recurrent tumor. Here's a very small recurrence on the lateral nasopharyngeal wall. Looks like a mass, but somebody had to prove it, so we did a biopsy with CT guidance. This was mucosa covered, so the surgeon would have had a hard time finding it. So when there is a differential, be part of the solution. Thank you so much for your attention, and I look forward to seeing everybody next year in our dedicated real setting. Thank you.
The third speaker of this session is the entertaining and capable Lawrence Ginsburg, who is centered at the University of Texas MD Anderson Cancer Center in Houston. Larry has had a major role in increasing the prognosis of these cancer patients and will discuss post-radiation imaging, radiation effects versus recurrent tumor.
Hi, this is Larry Ginsburg. I'm sitting here at home. It's ASHNR virtual edition. I got my cool background, my black background, and I'm wearing my blue COVID outfit, which is, shirt only, obviously. And so I'm going to give my lecture now, and my talk is on radiation necrosis. I'd like to thank Dr. Schmalfus and the ASHNR program committee for including me. So I will be talking about radiation necrosis, locations, bony versus soft tissue, often both, some of the clinical settings, and of course the radiologic appearance, and a little bit on differentiating necrosis from recurrence, which can be tricky. And then I'm going to talk about the GFP, which, if you remember from last year, is a special treat. It's not really a special treat. Anyway, where can soft tissue necrosis occur after XRT? It can occur in the brain, mucosal surfaces, and one more T's for the GFP. Where can bone or cartilaginous necrosis occur? Any place there's bone or cartilage. Skull base, temporal bone, especially TMJ, jaw, mainly mandible, occasionally maxilla, hyoid bone, laryngeal cartilage, and styloid process. So this is what I'm going to cover. There, of course, is an interrelationship between soft tissue and bony necrosis as well, in that one can often lead to the other, or is a prelude to it. So how do you make the diagnosis of XRT-related necrosis? Well, you have to know the patient was radiated. And how do you know that? You know that because you've scoured the medical records. You read it, or they gave it to you in the history if you were lucky. You know it from prior radiology reports. It may be that there's no prior radiology reports, but you can see there's supraglottic laryngeal edema, platysmal thickening, and clearly the patient has been radiated. So you also should know the port, right? Where was the patient radiated? Now, maybe you have that in the electronic medical record, or you know where the original treated tumor was, so of course you know that's where they must have radiated. And ideally, you'll know if the patient was reirradiated, because anybody who's been reirradiated has a far higher likelihood of developing a radiation complication. Did the patient go to the dental service? Because often these people have dental pain and they go right to the dental service at my hospital. So if I see a dental note, I know that this is probably what's going on. You have to force yourself to look at the bone windows. It's easy to omit that. You've excluded tumor recurrence and nodal disease, but you failed to look at the bone window, so it's very easy to forget to do that. So in radiation necrosis of the brain, when does this happen? Well, radiation necrosis in the brain happens in patients who've been radiated for sinonasal, parotid cancers, nasopharyngeal cancer, cutaneous malignancies, especially in and around the ear, because you can see the hat is not covering the ear, so that's certainly at risk. This guy was obviously having a smoke at the Yankees game. So what are we looking for in terms of imaging? Well, this usually takes at least several months to occur. Same thing with bony necrosis, but can evolve up to several years, and occasionally as early as the first post-radiation scan. It usually begins as small spotty areas of enhancement with a variable degree of edema and typically progresses, becoming more confluent, and it can occasionally become very scary and mimic a tumor. So this person was radiated and was initially asymptomatic. I think it was nasopharyngeal cancer, and then in this typical location, anteromedial temporal lobe developed this area of enhancement with some edema, and you can see that this clearly progressed. Ultimately, the patient had mass effect and seized. So this is scary looking, and you might be wondering if this was something else, but the way it evolved is very typically brain necrosis. This patient was radiated for sinonasal undifferentiated cancer. This is the kind of treatment plans that we see in our medical record, and this was a tumor that, to my recollection, did not initially spread intracranially, but clearly this portion of his brain was included in the radiation, and now he's got this area of enhancement with edema. And this patient subsequently recurred in his nasal cavity and required re-irradiation. And here's the re-irradiation port. So this person now, his brain has been radiated twice, and that's why he developed all of this really scary necrosis in the inferior frontal region. Necrosis of the mucosa is a major problem in patients who've been radiated for head and neck cancer. It may be seen in isolation or in association with osteoradionecrosis. It usually begins as an area of ulceration or a breach in the mucosa with air extending submucosally and a variable degree of enhancement. This is extremely painful and a major cause of a diminished quality of life in radiated patients. If there's no enhancement, it's very likely, almost completely unlikely, to harbor recurrent tumor. If there's just some surface enhancement, not really mass-like, still, you might be a little bit more worried, but this is unlikely to be recurrent tumor. If there's confluent or mass-like enhancement, then you have to at least start to begin considering a tumor recurrence. Now, this is guaranteed to be hot. Regardless of what stage it is or how much enhancement, this is always hot, and it's a classic pitfall because even though you need to consider, is this radiation necrosis? And just because it's hot doesn't mean it's tumor. And unfortunately, it is the case that sometimes radiation injury and tumor recurrence can coexist. So I don't mean to say that this is easy in all cases. But you want to avoid biopsying someone who has merely necrosis, because that can definitely lead to much more necrosis and or infection and badness. If soft tissue necrosis extends deep enough so that it reaches bone or cartilage, that can facilitate and lead to osteo or chondral radionecrosis. And it's also worth mentioning that just because there's no tumor right now, it doesn't mean that this patient can't recur in this location or adjacent to it anytime in the future. So this person was given 66 gray for a left tonsillar cancer, and over a period of months, initially the lingual surface of the soft palate looked pretty good, but now there's this just small ulceration. It doesn't really hit you over the head. There's no debris in it. It doesn't look like a classic ulcer. But clinically, this was an ulcer on the lingual surface of the epiglottis. This is a more typical ulceration. This person had been radiated 5 months earlier for oropharyngeal cancer, and now we see not only this breach in the mucosa, but there's gradu, there's debris in it. This is a very typical ulcer. And notice that the superior cornu of the hyoid bone is poking into it and is surrounded by air. More on this later, but that is a harbinger of osteoradionecrosis. This patient was radiated for the tongue-based cancer that you can see here. This is the port. And after the radiation, the PET scan was red. This area of increased FDG activity 3 months after XRT was read as residual malignancy is difficult to exclude. But there is a defect in the mucosa. We can see submucosal air and virtually no enhancement. This is a typical situation where you would not want to overread this PET scan as worrisome for tumor recurrence. But this led to a biopsy, and it was only necrosis and no tumor. This patient had a tonsillectomy and chemoradiation for a pharyngeal carcinoma, and he presented to us with a large, essentially gaping defect in his mucosa. This is a large area of necrosis, but Coincidentally, there was mass-like enhancement, and so this patient had concomitant radiation injury as well as tumor recurrence, and actually bled to death 2 days after this scan was obtained. This patient has a right tonsillar malignancy that you can see here. It's very obvious. And 6 weeks later, there's just some typical post-radiation circumferential mucosal enhancement, no breach, really nothing very worrisome here. But 8 weeks later, now it's starting to be more focally metabolically active over here, and on a CT subsequently, there's grade 2. This is a mucosal defect. This is clearly radiation injury. There's no abnormal enhancement here. And I told the doctor that this patient had necrosis and ulceration and that they could aggravate it by doing a biopsy, but I was told that the patient, quote unquote, smells like cancer and has a mass. I have to biopsy her. Well, that's what happened. It was all necrosis, and subsequently that necrosis got particularly gnarly and eventually extended to the bone, and this is what the ulcer looked like on physical exam, and this patient needed a mandibulectomy and a free flap, actually developed a fistula. It was nasty. Now, I don't know that that wouldn't have happened, without the biopsy, but it certainly happened with the biopsy, and I think perhaps could have been avoided here. All right, now the Ginsbergian funk pocket. I know you've been waiting for this. What is a GFP? A GFP is a mucosal breach that leads to a fistulous communication where the grade 2 extends submucosally, and where does it go? It goes nowhere. Maybe it goes nowhere, but food collects in there. Lunch goes in there, and it funks. That's why it's a funk pocket. And if it extends to a place where there's bone or cartilage, often the superior cornu of the hyoid or thyroid cartilage, and that can lead to chondroradial necrosis and more funk. So it can also ultimately lead to a fistula to the skin surface, and in really bad cases, if it goes posteriorly, it can lead to an abscess in spinal osteo. So here's a patient who was radiated with this treatment plan for that cancer. We have a typical ulceration here, but that ulcer continues. And this is going into a Ginsbergian funk pocket, which looks an awful lot like an abscess. And I'm not saying it isn't, but that can be the consequence of a GFP. Now, this one eventually led to the skin surface and became a fistula. And of course, it's hot on PET because it's inflamed or infected because saliva and lunch is in there. So this is a Ginsbergian funk pocket. It required surgery. There was no tumor in there. And eventually healed with a lot of tender loving care and some high-dose oxygen. This is another patient who'd had an extensive surgery. Many of these cases are very complex in their history. And this patient had a free flap for a malignancy of the oropharynx and developed necrosis. We can actually see the defect in the mucosa here. And here's this collection, and it's going close to the spine here. And this is how you end up with a retropharyngeal phlegmon or an abscess, and in bad cases, a spinal osteo. Osteoradionecrosis now. When do we see it? It's mostly in the head and neck. Mostly we see this in the mandible. Patients who have been radiated for nasopharyngeal or oral cavity or pharyngeal malignancies. It can be a tricky diagnosis if you're only looking at MRI because there's a lot of abnormal signal that can mimic tumor. It's important to realize that this is not just dead inert bone, but rather an inflammatory process because it's often exposed with an overlying mucosal defect, and this can lead to inflammation and ultimately infection. So the process can extend into the masticator space. On MRI, this can be very ugly. Again, this often exposed bone, and the dentists pick this up. What do we see on radiology? We see a mucosal, we see a cortical defect, usually on the lingual surface, occasionally on the buccal surface, but it can be a small cortical defect, ultimately leading to disorganized bone, lytic change, occasionally pathologic fractures. As I mentioned, if you don't scrutinize the bone windows, this can be easy to overlook. Pathologic fractures. Remember, you should never have air in your bone. If you have air in bone, something is wrong. That's not good bone. And this too can be aggravated by biopsy. So some of these patients can develop an infection, whether it's a phlegmon or a frank abscess. This is not uncommon. Maxilla is far less commonly involved in osteoradionecrosis. So here's a patient with a typical breach in the mucosa after radiation for a tonsil cancer, but now it's reached the surface of the mandible. There's a lingual cortical defect. There's abnormal enhancement or tracer activity rather, and enhancement in the masticator space. And this is an angry right mandibular osteoradionecrosis associated with soft tissue necrosis. As I mentioned, on MRI, this patient had been radiated for a skin cancer, has now pain and trismus. And if you only look at the bone, you're going to see abnormal T1, abnormal T2 signal, abnormal T2 and enhancement in the muscles of mastication on either side of the mandible, and that might be tempting to worry about as tumor, but really what we see here is classic disorganized bone. We see that there's air in the bone here. That's never good. This is exposed bone and necrotic bone, and this is osteoradionecrosis. This is a patient 5 and 11 months after 70 gray for a base of tongue cancer. We can see on the 5-month study the bone looks pretty good, but at 11 months there's defect in the cortex of this bone and ultimately a sequestrum of dead bone. This is what the exposed bone looks like when you look in this patient's mouth. This patient progressed and ultimately ended up with a masticator space abscess, which is not an everyday occurrence, but it's not rare on a busy head and neck cancer service. So here's another patient, 2, 6, and 12 months after XRT, healthy bone, small cortical defect, gaping cortical defect. And of course, it got worse, and despite hyperbaric oxygen, and it's always going to be hot on PET CT. So remember that hot does not equal tumor. Both of those patients needed mandibulectomies. This is just an example of maxillary osteoradionecrosis. We don't see it very often. How about osteoradionecrosis of the temporal bone? So patients who are radiated for parotid, external ear, skin cancers of the face, and nasopharyngeal cancer can develop a temporal bone osteoradionecrosis in any portion. Often it's in the external canal, occasionally in the mastoid or the TMJ. These patients can be, on physical exam, can have defects along the skin of the external canal, which allows bacteria to grow in. There are some predisposing factors, and we published a series of external canal osteoradionecrosis, but these are patients with poor wound healing, diabetics, for instance. They present with hearing loss, otorrhea, and a foul odor. Rarely, if it's a very advanced case, facial paralysis. And the imaging spectrum includes subtle cortical defects to flagrant bone breakdown. And on otoscopic exam, exposed bone is the hallmark. So here's a normal tympanic exam, otoscopic exam. And this is a patient with very advanced, flagrant osteoradionecrosis of the external canal with thickened and desquamating skin, and here we see exposed bone. This is a patient who was radiated with 60 gray for this horrible skin cancer. This is the treatment port, so obviously the temporal bone was in jeopardy, and I was sent this picture, and I needed the otologist to help me out with it. So really what we can see here is this exposed bone. This is just for orientation, but this is exposed bone along the external canal. This is a relatively minor case, but on the left posterior canal wall looks pretty good, but on the right side there's this small defect. And here's a more advanced case that I showed the picture of earlier, and a much bigger defect along the posterior bony canal wall. So this is temporal bone osteoradionecrosis. This is a patient who was radiated for skin cancer metastatic to the parotid gland, now has severe pain, which is aggravated by mastication. And although this is a subtle finding, the posterior margin of the right mandibular condyle is absent. The cortex is absent here, right? So we have normal cortex along the posterior wall of the left condyle, but on the right side it was gone, and then ultimately this condyle began to fragment, and there's some inflammatory enhancement in the upper aspect of this TMJ. So this is an advanced case of TMJ ORN. This is a patient that I have shown in the past, and it's a complicated story, but basically the patient was probably over-radiated someplace else for a skin cancer after surgery, after parotidectomy, and presented to us with altered mental status and ear drainage. And long story short, this is osteoradionecrosis of the temporal bone. And notice that there's intracranial air. So this patient was able to have air and thus bacteria extend intracranially and develop the brain abscess with restricted diffusion that accounted for the altered mental status. So I could show many cases of this, but I'm just going to briefly show you patients who are radiated for nasopharyngeal cancer often get a combination of necrosis in the roof of their nasopharyngeal soft tissue necrosis, which exposes the skull base, which is already radiation weakened or injured, and we can end up with this very nasty skull base type picture. There's no tumor here. This is all soft tissue and osteoradionecrosis of the skull base. Hyoid bone osteoradionecrosis, I still believe it's probably underappreciated. It may be confused with or coexist with recurrent tumor, which requires a careful analysis of imaging findings. We published a number of years ago a series of 13 patients, all of whom had been radiated and not uncommonly re-irradiated, that is for either recurrence or a second primary, so that the low tongue base got a pretty hefty dose of XRT. And most of these patients on physical exam will have an ulceration in the vallecula, sometimes with obvious exposed bone. And on CT, we see this soft tissue defect, and then eventually we will see air in contact with, that is, exposure of the hyoid bone, and ultimately that can predictably lead to osteoradionecrosis of the hyoid bone. It would be typical for the PET to be hot and deemed worrisome for tumor recurrence, but in a characteristic sequence, that's usually not the case. So this patient has a malignancy here, had been radiated previously, and now was re-irradiated for this supraglottic or transglottic malignancy here, and then subsequently developed this early small ulcer in the vallecula, and that ulcer got bigger, and eventually it came in very close contact with the hyoid bone, and now the hyoid bone is exposed, and it's frankly crumbling, as we can see here, and they gave hyperbaric oxygen and nothing helped, and now the hyoid bone is missing chunks of itself and is hot. Of course, this is angry because it's secondarily infected, and this patient required a hyoidectomy and a free flap. This patient is a little more complicated, was radiated for came to us with a tongue-based cancer and was radiated. We can see it was a low tongue-based cancer, and then subsequently developed what may have been a small ulceration over here, and that got hot. Okay, there's definitely a small ulcer here, but also there began some abnormal FDG activity in the low tongue base. And eventually this all kind of coalesced and progressed into a large collection, and I dictated that I was not really suspicious about tumor recurrence, but I was worried about exposed hyoid, and eventually, long story short, this ulceration developed several different prongs to it. They biopsied it and on the outside, and they got no tumor. These stories sometimes become complex sagas. We can see that there's a bit of exposed bone here, and even though the patient had hyperbaric oxygen, long story short, there's a lot of abnormal enhancement here. This is all a fragmented hyoid, which ultimately drained into a submental or anterior cervical fistula. So these cases can sometimes become complex sagas. This patient was radiated for the low tongue base or vallecular cancer that you see here, developed the usual exposure of the hyoid. There may even be some air in the hyoid. Air in bone is, of course, bad. And this patient's hyoid eventually fragmented and pierced the epiglottis and essentially presented in the vallecula, this is what it looked like on exam. And actually, the patient hocked up this fragment of hyoid and gave it to me as a gift. It's sitting on my desk. So this is hopefully going to get published. We won't call it hocked up hyoid, but I have several cases like this where a piece of the hyoid was eventually hocked up. Chondroradionecrosis is a significant problem in the management of laryngeal cancer. It can coexist with recurrent tumor, but patients are always warned that they may be cured of their larynx cancer, but nevertheless require a laryngectomy because of this necrosis, which can render a larynx non-functional. What are we looking for? Same as we've described in other locations. Air dissecting through a mucosal breach into the submucosa where air does not belong, exposure of bone or cartilage, and ultimately fragmentation, dissolution of this bone, usually the thyroid cartilage. Occasionally, they amputate a piece of the bone. This is a patient who's been radiated elsewhere for hypopharyngeal carcinoma. Because of a so-called abnormality on PET-CT, he had 3 biopsies, and biopsies are not good. And so we can see that this hyoid bone is not only exposed to air, but has air within it. And this is a pretty flagrant case of arytenoid chondroradionecrosis. This patient already got a somewhat deformed arytenoid cartilage, but between this study and the next study, that bone actually must have been expelled, swallowed, aspirated, hocked up. I don't really know, but I do know that it's gone. We don't see as often chondroradionecrosis of the cricoid cartilage, but this is such a case where we can see this clearly normal cricoid on the right side and clearly abnormal dissolving cartilage on the left side, and naturally it is hot. And the final thing that I'm going to show is styloid process osteoradionecrosis. I think that this is pretty unusual, but it's usually patients who have been radiated for oropharyngeal cancer. They present with a triad, with a constellation of symptoms that are typically seen in so-called Eagle syndrome, with a giant ossified stylohyoid ligament that is throat pain, dysphagia, otalgia, and sometimes trismus. And what we see radiographically is a mucosal defect which extends from the mucosa to the styloid, and then air surrounding or within the styloid. And we published a series of this entity last year. This was a 69-year-old who was given 70 gray for a right tongue cancer, and we can see there is this small mucosal defect here that is extending towards, and actually then we can see air surrounding the patient's right styloid process. So in conclusion, radiation therapy is a mainstay of treatment for head and neck malignancies. Conformal techniques and more modern radiation oncology techniques have reduced but not eliminated the incidence of necrosis. And this is especially true if a patient is reirradiated, which may happen either in the case of recurrence or a second unrelated malignancy. These findings can be very subtle or very flagrant depending on where we catch it along its course of development. For soft tissue, usually there's a small and then growing mucosal defect with or without debris or an obvious ulcer. And in some cases, this can lead to a Ginsbergian funk pocket and infection and pain and problems. And in turn, if this extends to a bony or cartilaginous surface, osteoradionecrosis or worse. Bone or cartilage necrosis is often preceded or accompanied by a soft tissue defect, exposed bone, ultimately leading to a cortical defect, and then more advanced, disorganized lytic changes in the bone, pathologic fracture, and sometimes secondary infection. It's important for the radiologist to keep these things in mind because we like to avoid biopsy when possible because it can lead to bigger problems. These patients will sometimes require debridement and hyperbaric oxygen, antibiotics, or rinses to help them with to prevent the infectious sequela. PET will almost always be hot in cases of any kind of necrosis, so it's important that the radiologist resists the urge to call this tumor, which unfortunately can still develop. And of course, these patients always require serial imaging and vigilance. So I'm going to thank you for listening.